Floor is yours.
Good morning, and thank you for inviting me. And I'm sorry about the technical issue here. I'm happy to see that there's such a large group of caregivers seeking information and support at this conference. In line with the conference theme of caregiving with hope and inspiration, I wanted to share just one thing that inspires me every day in my work in the dementia research program, and that is the courage of our patients and their caregivers. There's so many things you don't have control over as a caregiver, but I see on a daily basis people doing their best with the two things that they do have control over: their attitude and their effort. Attitude about being a caregiver and the changes and oftentimes the turmoil that brings to your lives, and effort, meaning taking action to become educated, seek out resources, navigate the healthcare system, and to be an advocate for your loved one. So this morning, I'm going to give a brief overview of how Alzheimer's is currently evaluated and treated, and then go into what is new and what we can offer at Georgetown. I expect this will take about 55 minutes, and then I'm happy to take any questions. Next slide, please. This should be a picture of my colleagues. Our director is in the back in the middle there, Dr. Raymond Turner, a neurologist. He's an expert in memory disorders. There's 4 nurse practitioners that provide all the patient care. Dr. Turner routinely weighs in on consultations when needed, but he doesn't tend to have his own panel. Our website, which is memory.georgetown.edu, describes in detail our research program and the staff that we have. Most of them are pictured here. Next slide is our mission. Our program is really twofold, the clinic and the research program. Essentially, our clinic, we help to offer a diagnosis to get to the diagnosis. And if patients are eligible and interested, we offer participation in clinical trials. If patients aren't interested in trials, then we usually refer to a community neurologist or a doctor at Georgetown who manages ongoing dementia care. The reason we operate this way is because of the volume of patients, and also because our focus is on finding a cure through research of new treatments, primarily new drug therapies. If you are seeking a memory evaluation for yourself or for a parent or a friend, it's best really to start with talking with your primary care doctor or clinician who can initiate a basic evaluation and a review of medications, and then if needed, a referral can be made to the Georgetown Memory Disorders Program for a more in-depth evaluation. We also receive a lot of referrals from neurologists in the community requesting second opinions or requesting a research information visit where a clinician will talk with the patient and family just for learning about options for clinical trials. If you do call to make an appointment, Carolyn, who's our program coordinator, she's going to ask you to send records because we're really a primary memory problem clinic. For someone who's, for example, had a stroke, they would best be evaluated in the stroke clinic. So we do the records review first because we want to make the best use of your time and also make sure we're the best service to provide an accurate diagnosis. The second part of our program is the research program on the right. Often people seen in the clinic do enroll in our clinical research, but most of our volunteers are referred by outside clinicians, and patients often keep their own primary care providers near their home. People diagnosed with mild cognitive impairment or Alzheimer's may be eligible to enroll in clinical trials, and now we also enroll cognitively normal people who are at higher risk. And often this risk is from family history. We welcome diversity in research volunteers. This is an important part of obtaining accurate scientific results on how drugs work in all people. We also have an autopsy program. This is people who have participated in our program are usually eligible, often many years after they participate in our program. They can come back to us if they do want to have an autopsy, because brain tissue examination by a neuropathologist is really the most accurate way to confirm the diagnosis, and we do have a neuropathologist on staff. The next slide is my objectives today. I'd like to review how Alzheimer's is diagnosed and the current treatment. And Dr. Ravens gave a nice overview of that yesterday. Provide education about clinical research, discuss lecanemab and other anti-amyloid antibodies under study, and highlight the current research opportunities that we offer. The next slide is scope of the problem here. Complications of Alzheimer's disease was the 6th leading cause of death in America in 2019. In 2020 and 21, it dropped to 7th because of COVID, taking the number 3 spot. New and effective treatments for cancer and heart disease are allowing people to live longer. And age is the primary risk factor for Alzheimer's. You can see here that on the graph on the right, the breast cancer, prostate cancer, heart disease, stroke, and HIV have dropped as causes of death, but Alzheimer's has risen as a cause of death by 146%. This is from 2018, but the new statistics are similar. And I often get the question, do you actually die from Alzheimer's? And the way we figure that is, the CDC considers a person to have died from Alzheimer's dementia if the death certificate lists Alzheimer's as the underlying cause of death. And that's defined as the disease or injury that caused the train of events to lead directly to death. So it's dying from complications of severe dementia that can lead to things like immobility or swallowing disorders or acute respiratory problems, things like that. And the next slide, dementia is also called major neurocognitive disorder. Dementia is a broad term characterized by symptoms of cognitive and functional decline. Symptoms vary depending on the cause. I see a lot of patients, and I don't see any two with the exact same symptoms at the exact same time. It really varies, but it can include a lot of different symptoms like memory loss, difficulty communicating or finding words, difficulty with visual and spatial abilities, reasoning, problem solving. You're probably, many of you are very familiar with this. It can also have psychological symptoms. Throughout the disease course, probably about 80% of patients do have some psychological symptoms at some point, such as depression, anxiety, paranoia, agitation, things like that, which we can often help with medication. The next slide, what's the difference between Alzheimer's and dementia? This is probably the most common question that people ask me. As you can see, there are many types or causes under the large umbrella term of dementia. Next slide, the different kinds of dementia can be sort of elucidated in the pie chart here. Alzheimer's disease is the most common type. About 60% of all dementias are from Alzheimer's. Lewy body accounts for about 4% on the bottom left there. And that has usually different symptoms such as visual hallucinations and changes in gait. Mixed dementia is about 10% in the tan area. Vascular dementia is about, in the blue area, about 17%. Those are usually from a stroke. And then the other dementias combined is about 6%. So frontotemporal, late stage Parkinson's disease, people can start to have dementia and some other variants. The next slide, dementia is really underdiagnosed and undiagnosed. So it can start typically very insidiously and be attributed to normal aging. Patients often seem normal socially and can explain away any difficulties they're having, and they don't really look physically ill. So an evaluation tends to get delayed, and a lot of patients can't self-assess very well. This is often part of the illness, so they don't seek out an evaluation. The next slide. How can you tell the difference between normal aging and the beginning of pathology or disease? It's often hard to tease this out, even for experienced clinicians. I'll let you read through this on your own, but the first questions I ask to determine if there is a problem is, what are the new difficulties for them? Do they forget events, details of events and conversations? Do they have new trouble with planning, organizing, or doing tasks that they've always done, such as a change in ability to manage the finances? Or are there new difficulties with understanding explanations, learning new information, either things they hear or things they see? Because the ability to learn new things is the hallmark of a healthy brain, regardless of age. If there is an inability to learn something new, especially when the information has been given multiple times and this is a change for them, that's a sign that there could be something wrong. Conditions that may contribute to memory changes, next slide, there are a list here of medical issues that can contribute to changes: untreated depression or other mental health issues, alcohol overuse, drug use, other illnesses and infections that stress your body can sometimes temporarily contribute to memory changes, endocrine diseases that are not well managed, such as a poorly controlled thyroid or diabetes, and sometimes medications interfere with memory, sometimes pain medications, long-acting sleep or anxiety medications. I wouldn't want you to change anything, though, until you talk to your doctor, because there always has to be a risk versus benefit assessment. Untreated sleep disorders such as sleep apnea and a history of head trauma, especially with if there's been some loss of consciousness, all can contribute to memory problems. And usually we'd want to treat these medical problems first to uncover if there is an additional underlying problem, such as the beginnings of Alzheimer's. The next slide is mild cognitive impairment. We know now that Alzheimer's starts in the brain many years before any symptoms show. This is called the preclinical stage on the left there. And we always have to detect, we do have ways to detect this in research, which I'm going to elaborate on in a bit. Mild cognitive impairment is that middle stage between normal aging and dementia. It's often referred to as a prodromal Alzheimer's disease, where a person has an obvious new memory problem, and they start to rely heavily on writing things down. They may have sticky notes all over, and they have visual prompts or verbal reminders. I mean, a lot of people rely on that anyway, but if you're doing it more and it's really new for you, then that might be the beginnings. They can do the same things they did before. It just may be a little harder. It may take them a lot longer. That said, not all mild cognitive impairment turns into Alzheimer's. After about 20% can revert back even in a year or two. Mild cognitive impairment can have other causes besides the beginnings of Alzheimer's. The statistics are that about 10 to 15% of patients diagnosed with mild cognitive impairment per year progress to Alzheimer's. And often family members and friends notice the patient's change in short-term memory, and the patient doesn't. And the time frame for this, typically for this picture of the graph of noticing changes down to severe Alzheimer's would be 20 years or more, although it's very variable. The next slide is about the evaluation. You should, like I said, start with your primary care clinician who can initiate all of these things. The Medicare wellness exam does now cover an annual basic cognitive evaluation. So you can make an appointment just for that. It usually starts with just a short cognitive test. They may not need to do the rest of things on this list. The brain MRI is often normal in Alzheimer's. We don't do a brain MRI to see Alzheimer's, because it doesn't show up on an MRI or a CAT scan. We do these scans to see if there are other reasons, such as stroke or lesions or tumors contributing to memory problems. The MRI just looks at the structure of the brain, but we can see often the changes of the beginnings of a memory problem with an FDG PET scan, which is a sugar PET scan. It uses a sugar tracer through an IV in your arm. It looks at the function of the lobes of the brain. The problem is this is not covered by insurance. It's not often covered. It can sometimes be covered. The diagnosis is usually made without this scan, by a clinical evaluation, ruling out other medical problems that would be causing memory problems. And of course, in our clinic, we always ask the patient be accompanied by an informant who can provide observations, accurate observations as to the changes that are occurring. Now we're on Alzheimer's disease treatment with medications. There are no readily available FDA-approved medications for mild cognitive impairment. A cholinesterase inhibitor may be indicated if dementia due to Alzheimer's is diagnosed. These drugs work by slowing down the breakdown of acetylcholine, which is an important neurotransmitter. Neurotransmitters are the cells that carry messages from one brain cell to the next, or the substance that carries messages. Donepezil, galantamine, and rivastigmine are given for all stages of disease. they have the same efficacy profile. They all have the same effectiveness, and they work the same way. When the symptoms progress, memantine is usually added. It's approved for moderate to severe disease. We don't know why it wasn't approved for early disease, but it didn't seem to help. It works on a different neurotransmitter, glutamate. All of these are treatments. They're FDA approved as treatments, but they're not disease modifying. They don't really get at the underlying problem. Aduhelm or aducanumab is now, since the summer of 2021, FDA approved for mild cognitive impairment and early Alzheimer's with evidence of amyloid in the brain. Amyloid is that naturally occurring protein that everybody has, but in some people, as they age, the brain doesn't clear it and it builds up outside the neurons and forms plaques. This amyloid beta plaque is considered toxin or an antigen. The anti-amyloid medications are antibodies that are given intravenously that target and break up the amyloid beta plaque, and they clear it from the brain. Currently, this one is not covered by insurance and still under study in a clinical trial sponsored by the Center for Medicare and Medicaid Services. We're not offering that trial there at Georgetown. So this is kind of an overall, the next slide, a summary of the FDA-approved drugs for Alzheimer's. We talked about the first three, and memantine, and the Namzaric is a combination of the two drug classes above there, and then I mentioned Aduhelm. The next slide is about treatments. I'm just going to mention that well-chosen antidepressants can be very helpful for treating the behavioral and psychological symptoms that accompany Alzheimer's disease. Apathy is an early hallmark of the disease, kind of losing interest or motivation, and depression and anxiety can go hand in hand with memory loss. The brain neurodegeneration that occurs can cause or contribute to both of those. And on the right side, non-pharmacologic interventions can also be helpful in managing the disease. I could probably learn more. Caregivers could probably add a lot more to this list. Controlling hypertension, improving sleep, preventing accidents, anticipating problems, and intervening before they occur, such as stopping driving, providing good nutrition, and having a structured routine with exercise, socialization, enjoyable activities can also be helpful for managing the patient's illness. You may be, the next slide here is a little busy. You may be looking at this saying, oh no, too much science. But I included this mainly to represent what we know about how Alzheimer's starts and progresses, going from the middle top arrows downward, a series of steps that occur in the brain along the Alzheimer's disease course. To the left of this pathway, I don't have a pointer, but to the left of this pathway, we can see in the upper left corner things that impact or accelerate the disease, such as age and genes. You see Down syndrome on this too, as patients with Down syndrome are genetically predisposed to eventually getting Alzheimer's because they have a mutation on chromosome 21. And in the bottom left, below the picture of the plaque and the tangle in the brain, you can see by the arrow where the medication treatments we currently use impact the disease. On the far right are how we can see the disease on clinical tests. So the therapies we're studying in research are aimed at attacking the disease towards the middle top where the process starts, that, between the first and second arrow, to reduce the buildup of amyloid and prevent it from turning into plaques outside the neurons and tau protein tangles inside the neurons. And we expect that just like any other chronic illness, such as diabetes or high blood pressure, there will eventually be a cocktail of different types of medications that work at different points in the disease process to slow the disease or contain it before we actually find a cure. Next slide. I get a lot of questions about supplements and new therapies that are directly marketed to consumers. It's important to remember that the FDA doesn't regulate these or approve their labeling. Most of them have not been studied in double-blind placebo-controlled trials or in a scientific way. Many have some kind of seal on the bottle, which means that they have a greater likelihood of really having the product that they are advertising in the bottle, but it doesn't guarantee safety or that it works. So adding supplements to your drug regimen can also cause unwanted side effects. So if you are on a lot of medications, you probably want to avoid supplements unless your doctor approves it. Effectiveness of new therapies always should be supported by peer-reviewed scientific literature with results from controlled clinical trials, not just personal anecdotes or claims from someone selling something. So you're very vulnerable when you have a progressive illness to wanting to try things, but you do have to be careful and use good judgment in what you add to your regimen. The next slide is on biomarker changes. Another little bit of science here. I won't spend too much time. This is a nice visual of the changes that occur in the brain and when they can be seen in the body as the disease progresses. This is not part of a standard clinical evaluation. Rather, what we have learned from following patients over time in research. So the biomarkers, and again, a biomarker is something we can see or measure in the body. Biomarkers change from normal to abnormal on the vertical y-axis as a function of disease stage, seen on the horizontal or the x-axis. The far red curve, or the left red curve, is when the amyloid protein starts to build up in the brain. So you can see it's way before people start to have symptoms. The next curve to the right is the orange line. It represents subtle changes seen on an FDG or that sugar PET scan, which looks at how well the lobes of the brain are actually working. And then over time, probably years, tau protein, which is represented by the green line, which is a byproduct of neuronal injury, can be seen in the spinal fluid. And then the blue line, a little bit to the right, we can see changes in the brain by research MRIs, and then we finally see changes in cognition, or the purple line, and functional decline. More trouble doing things they've always done is when they start getting into dementia, or the brown line. So it's a long course of changes in the brain and the body. The next slide is clinical research is when people or their biological data is studied in order to understand health and disease. And this is from the NIH website explaining that human volunteers are critical for testing new drug therapies. And I just want to give a shout out to anyone who has participated with their loved one in a clinical trial. I saw some familiar names in the chat box yesterday, and even if it did not help them, you played a huge role in helping scientists move forward to figure out what may work. Volunteering may give access to new medications, which may help you or others, including future generations of family members. And participation in research also provides regular monitoring of your health. Next slide is on the phases of a clinical trial. If you are interested in joining a trial of a new compound, you should know where it is in the pipeline of development. So phase 1 is a small sample of brief testing of safety in the human body. Phase 2 is usually a little longer period of time, maybe 18 months, test different dosages for tolerability and safety. Phase 3 is getting into looking at, continuing to look at safety, but also efficacy. So in a larger group of people for a longer period of time, typically in Alzheimer's studies, this is usually about 1,000 people for 2 years, and the studies are worldwide. And everybody has the same illness and the same disease stage. And the scientific question for most phase 3 studies is, does the group who received the drug have a slower rate of progression? Can they think better? Can they function better than the people who did not get the study drug? So usually the FDA will want 2 large placebo-controlled phase 3 trials to show safety and efficacy before they will consider approval. And phase 4 is looking at efficacy, post-marketing, and safety over longer periods of time after it's in use. And the next slide gives us some hope for the future. There's a lot of AD research going on, both using medications on the left, pharmacologic, and using other therapies or non-pharmacologic on the right. I'm not going to go into all these, but you can see that many ideas are being tested in clinical trials, which is really encouraging. If you want to see trials that are in progress, I'm going to encourage you to go to clinicaltrials.gov, the National Registry of Trials, and you can search under Alzheimer's disease, or you can search under the name of the therapy you're looking for. Sadly, the number of diagnosed patients that enter clinical trials is pretty low. It's about 1% nationwide. Part of this is because most people don't live close to a trial site, or because they don't seek an early diagnosis and they miss the window for enrolling, or because they don't have a healthy or available caregiver. Again, we can't make progress without human volunteers. And this next slide breaks down the different types of therapies under study. Just if you're curious, the amyloid therapies are the most numerous in phase 3. ALZFORUM, alzforum.org is a good place to follow the science and progress behind the different therapies under study. It does tend to be pretty heavy science, but there's some nice news blogs where you can kind of, or news postings from the scientists, you can kind of keep up with what's coming. Most of the treatment trials are double-blind, randomized, placebo-controlled, meaning everyone's blinded to what the volunteer is receiving, and some patients will receive the study drug and the other, the placebo or the fake drug. Most of the study drugs we have are given by IV or by injections like a flu shot, and the studies are usually about 2 years in length. Next slide, here's the good news. Lots of progress. So we have a better understanding of risks and prevention. We discussed how we can see the amyloid and the tau proteins by brain PET imaging and research, and even more recently in the past year by blood tests. We now know more about the preclinical and prodromal stages of Alzheimer's, and the first anti-tau studies were completed. Funding has increased from $448 million in 2010 to, I think it's $3.5 billion now, so it's really been going up, and we have a better understanding also of the non-Alzheimer's dementias. And there's a lot of more information sharing, which is really opening the door for more therapies to come. The next slide is on the anti-amyloid antibodies, which is kind of the focus right now, or in the news a lot. There are anti-amyloid drugs currently under study, or these are the ones that are currently under study at Georgetown. The ongoing treatment trials at Georgetown are highlighted in yellow. Some are finished to the first part, the blinded part of the study, and are in what we call open label, meaning patients don't know if they received the study drug in the beginning, but they are definitely now receiving the drug. So they completed the blinded portion, and then they go into the rollover part, which is definitely getting the study drug. And the second generation in the title here means they act on a different form of amyloid than the first drugs we studied, more than 10 years ago. So we know these drugs work to reduce the amount of amyloid. Again, the main scientific question is, does it actually help the patient to think and function better? To the left are the 4 drugs under study. Aduhelm remains under study, needing more proof of efficacy, and the other 3 are completing phase 3 trials. All of them are expected to announce efficacy results in 2023. I think lecanemab is going to be first in early January, and then probably gantenerumab, and then donanemab probably hopefully by the summer. So we're really looking forward to getting these phase 3 results. Lecanemab is also under study for prevention in the HEAD study, and it's the only one here listed that is still enrolling at Georgetown. Next slide is what happened to aducanumab. I'm not going to spend a lot of time on this because I know Dr. Ravens explained it well yesterday, but in a nutshell, the 2 phase 3s were completed. Usually the FDA needs 2 phase 3 trials to indicate statistically and clinically, or how the patient performs, that yes, the volunteers who received the study drug fared better than the volunteers who did not. But in this case, the analysis was more complicated because the EMERGE study indicated yes, helpful, but the second study, ENGAGE, indicated yes, but only in a subset. So the drug was approved in an accelerated pathway based on the way it was able to lower amyloid, but ultimately, the CMS said it would not cover the drug, and insurances won't either because it needed more data. And they're going to offer another trial to get that data, but not at Georgetown. And this drug, you should know, also does have serious side effects and risk for serious side effects, including infusion reactions and changes in the brain related to the removal of amyloid, which is called ARIA. And I just wanted to go to the next slide and talk a little bit about ARIA, because all of these anti-amyloid drugs can have a side effect of ARIA. It's a known side effect. It can sometimes mean the drug is working, but it can happen. So I wanted to spend a minute. Here are the pictures of ARIA looking from the top of the head down on a brain MRI. You can see the eyes at the top. The side effect I mentioned, amyloid-related imaging abnormalities, only occurs from receiving the anti-amyloid drug. When the plaque is removed, something has to fill that space when the plaque comes out, and sometimes it can be like a fluid shift. We call that vascular edema, or a pinpoint hemorrhage called a microhemorrhage. So that's what we look for. The radiologists are trained to look for that to see how much is occurring. It's seen on a brighter, whiter portions. The bottom left picture is actually the most, where you can see it the most, which indicates more fluid shifting. Usually the ARIA is asymptomatic, so patients can't feel it, and that's why we have to do the brain scans, but occasionally someone can have symptoms, or it can become more serious. And we treat the ARIA, if it is deemed serious, by stopping the study drug and letting the brain absorb the fluid. Again, patients can't usually feel it. We know that giving an anti-amyloid drug in a titration, so starting at a low dose and gradually increasing it over months, decreases the side effect. And as we're studying it more, we're getting better at decreasing the side effect. Next slide is the symptoms of ARIA. So if a patient does have symptoms, if you're in an anti-amyloid study, we're going to ask you if you have any of these side effects, which could be a symptom, which can be headaches or dizziness. Again, you can only have this if you are receiving an anti-amyloid drug in a study. Next slide. Alzheimer's can be divided into the familial and the sporadic type. Familial is very rare. It's less than 5% of Alzheimer's, and it's caused by a genetic mutation, which very few people have. And that's in presenilins or another chromosome mutation on APP. Most Alzheimer's is sporadic, which is not related to a genetic mutation, and can be early onset before age 65 or late onset over age 65. With sporadic AD, you may have a genetic risk, a certain APOE gene, which is not considered to be a cause of the disease. It just indicates that you're at higher risk as you age. We don't know the direct cause of sporadic AD, but we can identify some of the proteins that represent disease. And there are some good genetic fact sheets online at nia.nih.gov, Alzheimer's disease genetic fact sheets, if you want to read more on that. So the next slide, APO4 increases risk. So being a 3-4, you get one gene from each parent. Being a 3-4 puts you at slightly higher risk of getting Alzheimer's as you age. Being a 4-4 puts you at even higher risk. There aren't very many people that have 4-4. However, you could be a 3-4 or a 4-4 and never get the disease. So for that reason, we don't routinely check it as part of an evaluation. We tend to use the genotyping, checking for APOE more in research, because if you are a 4-4, you're at higher risk of having the side effect of ARIA from the anti-amyloid drugs. So we kind of use it as more of a safety check if someone's going to be in a clinical trial. But the next slide is on our biomarker discovery validation program. So this is a list of biomarker studies underway at Georgetown. Many are in collaboration with other researchers. The LEARN study is the control arm of the A4 prevention study. So that's a prevention trial I'm going to talk about in a minute. Those are all cognitively normal people who are just coming in for evaluations. They're not actually, they didn't qualify to get the study drug because they didn't have elevated amyloid. Of the enrolling studies in yellow, I will show a short video clip about ADME in a minute. Steve will put that on. The trial ready cohort is a group of people who are referred from the APT web study, and I'll talk more about that in a minute, which anyone over 50 can join, and I'll go into that. Early onset is the lead study, is a longitudinal non-treatment study for people affected with Alzheimer's at an early age between 40 and 64. That's 3 study visits in 2 years. And the functional MRI is a study that asks you to perform a visual task in the scanner. That's Dr. Yang, and we're looking for early indicators of cognitive change. Language changes in Alzheimer's disease is a collaboration with a Marymount researcher. It's a one-time study visit for a language task. And the bottom one, imaging neuroinflammation, is a collaboration with NIH that we're doing. You'll go to NIH for 3 or 4 visits. They're looking for anybody with neurodegenerative diseases. They're trying to discover an inflammatory biomarker. So that's a very worthwhile study as well. The next slide is our treatment trials for patients diagnosed with mild cognitive impairment or Alzheimer's. The top 4 anti-amyloid studies are all ongoing, and they're close to enrollment with results pending, like I said, in 2023. And the next 5 trials in yellow are currently enrolling, and I'm going to tell you a little bit just about each one. Next slide, the lecanemab is the Clarity study. Lecanemab is an anti-amyloid compound given by IV every 4 weeks. And this study was for 18 months for patients with mild cognitive impairment and early Alzheimer's. All patients who entered the trial had to have a brain PET scan as part of the screening process to confirm the elevated amyloid. The results have come out. Biogen and Eisai have announced that there was a slowing of disease progression measured by a standard clinical rating scale looking at function. And there also was the side effect of ARIA, but it was lower than aducanumab, and most were asymptomatic. And this drug has been submitted to the FDA for approval, also in Europe and Japan. And we're hopeful that to have results by January 6th. They said they're going to come out, but they may kick that can down the road. We don't know. And then the next slide is about considerations. So if lecanemab were to be FDA approved, we know from aducanumab, the first one, which opened the door for this class of drugs, that there will be other things to consider before it would be made available. Medicare and insurances would have to decide if they would pay for the expensive PET scans to determine if each person has elevated amyloid in the brain before starting it. Also, appropriate use guidelines would have to be established for clinicians to give them prescribing guidelines and to help in determining risk versus benefit for the individual patients based on the science from the trials. And volunteers currently in trials will need to be given options on what is best for them. So some trials could stand to be disrupted if people left them to receive a new drug. And then also other factors for clinical use would be cost and availability. And also, since Alzheimer's is a progressive illness, it may be hard for families to notice any benefit from this drug because if people would still progress, and it's hard to notice sometimes if things are helping. Okay, so the next slide is just I'm going to list the 3 that are looking good. Gantenerumab, or the GRADUATE study. It's another anti-amyloid drug given IV. It's a different delivery method, so it's not it's not IV. It's subcutaneous every 2 weeks. So this could translate to an easier use. Something that people could do at home down the road. Well, we'd have to see. It's they are also starting a prevention trial called Skyline, and we're not a site for that, but that is a prevention trial that's ongoing, enrolling. The next slide is on donanemab, or the Trailblazer study. This is the most aggressive anti-amyloid compound in phase 3, and it also has side effects of ARIA and nausea. And it is also, like I said, results in 2023. So waiting for those. Next slide. Now I'm finally getting to what we can offer at Georgetown in terms of joining a study. Here are 3 different phase 2 trials of other therapies under study, all for mild cognitive impairment or mild Alzheimer's, usually a score of around 20 or 30 on that MMSE or mini mental status exam. That short office test would be needed to be eligible, so that indicates mild disease. We also go by functioning as well, but that's sort of the first brief hurdle. Autonomy is a phase 2 anti-tau, so trying to look at removing the tangle inside the neuron. The volunteer would have to have a blood test and brain PET scan showing elevated tau at screening in order to qualify. Signal AD is sponsored by Vaccinac. It's investing in papinimab, which has been studied in other diseases and is now being looked at in, I think, oncology as well. And they're looking at a novel higher dose in this early phase 2 trial. It may play a role in the immune inflammatory response. And Invoke is sponsored by Elector, and it's testing an antibody that may activate the clearing of amyloid as well, and may provide some neuron protection. So those are all 3 good possibilities that we're currently enrolling for. If you're interested in trials, we can help you figure out which one might be most suitable. And moving along to the next slide, which is outlining the MIND study. MIND stands for Memory Improvement Through Nicotine Dosing. And this is kind of interesting because it's a different type of study. We're enrolling for the study of a nicotine patch. Nicotine often doesn't sound appealing when I mention that, but it's not really nicotine that's bad. It's the tar and the toxic gases that are released from burning tobacco when you smoke that has caused health problems. So we know that there are nicotinic receptors in the brain that may help with memory and thinking. And we're studying this patch form to find out, one way or the other, if it might be one part of that cocktail of medications that might be helpful. And it's a daily patch form of treatment that requires visits only every 3 months for about 2 years. So if you have mild cognitive impairment, you want to try something, you could do this in the form of the clinical trial. There is a chance of placebo and a chance of the patch. Nicotine does have a side effect. These patches can cause some stomach upset. That's why they give them in a titration, but that's just a possible side effect. It's not guaranteed that you would have any problem with it. The next slide is on the MAP study. We're really excited to be part of the metformin Alzheimer's prevention study. And metformin is a currently used medication to treat diabetes. We hope that it can, we're looking at it to see if it can help memory and other indicators of Alzheimer's, the thinking being that good control of blood sugar may help prevent aging and protect the brain. Metformin's main side effects are related to stomach upset. So this is also given in titration, slowly going up on the dose. We're enrolling older adults over 55 who have mild cognitive impairment. If you are underweight or have diabetes, you can't participate in the study. So people who are a little bit overweight, don't have diabetes, are really perfect for this study if you have mild cognitive impairment. The next slide is just to mention some trends in clinical research, trending toward using biomarkers, what we can see in the blood and spinal fluid to do the blood test for the protein. This helps to confirm disease and direct the combination of diagnostic tests and therapies. There's also a shift toward earlier intervention, trying to identify and engage volunteers before people have symptoms or when they first get diagnosed with mild cognitive impairment. And web-based screening tools are turning out to be a successful way to do this. And finally, I mentioned increased funding and focusing on diversity. And the next slide just talks a little bit more about our underrepresented groups that we're targeting and that we hope will take an interest and participate, so we can really get more accurate research and thereby develop more accurate treatments. The bulk of clinical research is on Caucasian populations, and according to Us Against Alzheimer's, which is an advocacy group that leads to a lot of efforts for increased awareness and funding for Alzheimer's, Black Americans are twice as likely as non-Hispanic whites to develop Alzheimer's, and Latinx are 1.5 times as likely. And underrepresented groups are defined here as Black or African American, Hispanic, Latinx, Indigenous, and Native American, Asian, Native Hawaiians, and other Pacific Islanders, whatever people identify with. And now we're finally getting into prevention trials, and I think this provides the most hope for the next generation. The first prevention trial was a nationwide study, which is now fully enrolled with almost 1,200 people. I think it was 1,169 people aged 65 to 85 with elevated brain amyloid. And these people were all cognitively normal. And they volunteered to come in every month for 4 years, and also to get some brain scans and get this anti-amyloid drug or the placebo called solanezumab. And now we're finally going to get the results early next year to see if it helps to prevent the onset of memory problems. And in yellow is the AHEAD study. So we are currently enrolling for the AHEAD study. I think this is a great opportunity if you're at risk for getting Alzheimer's to participate in something new. It is using the same anti-amyloid drug that is called lecanemab that is being used for treatment now, and will come out with efficacy results for the treatment part of the drug if it works in people with mild cognitive impairment and Alzheimer's in January or around that time frame. And we're just starting to enroll for the prevention trial, and the treatment is given either, it's kind of interesting because they're doing a PET scan, and if you have really elevated amyloid, then you would get randomized to a more aggressive treatment every 2 weeks. If you have just a little bit of elevated amyloid, you would get randomized to go just once, get a treatment just once a month. So they're looking at 2 different treatment arms. Next slide. The overarching aim of the AHEAD study is to get ahead of Alzheimer's disease, to prevent or delay the onset of the disease across a diverse population. And we can see here a research brain PET scan, and this is an amyloid PET scan, not a sugar PET scan. This is using an amyloid tracer. Again, looking from the top of the head downwards. In the middle, we see the ventricles, and on the far right side, we can see a normal brain. The middle brain has a brain with amyloid showing up in red, but maybe no symptoms. As we know, amyloid builds up before you have symptoms. And at the far left is a lot of amyloid or red, and that would be a patient that does have symptoms. Next slide is the video. Steve, if you want to talk a little bit, show the AHEAD video.
Okay, just hang with me here real quick. I'm going to pull it up. And let's see. I'm hoping folks are going to be able to hear this okay. So here we go.
Right now, as a world, we're facing a terrible viral pandemic. We're struggling in our country with clear racial injustice, but we're also facing an epidemic of Alzheimer's disease.
By 2060, it's estimated that 15 million people will have Alzheimer's disease.
And we know that Alzheimer's disease disproportionately affects communities of color.
It's extremely important for us to achieve an appropriate level of diversity to ensure that all of our populations can get access to the best therapies.
Even though we're in very challenging and unprecedented times, Alzheimer's disease will not wait. So we must move forward right now to help fight this terrible disease.
The AHEAD study is a new clinical trial that is targeting removal of amyloid from people who are at high risk.
Amyloid is a protein that builds up in the brain years before people develop the symptoms of Alzheimer's disease. In this study, we aim to reduce the level of amyloid plaque by using study medication to hopefully protect them from developing cognitive decline.
We target to recruit about 1,400 people, but to do that, we have to screen about 8,000 people.
People ages 55 to 80 can enroll in the AHEAD study. We are aiming earlier in the biological process of Alzheimer's disease than we've done before.
I got involved in the AHEAD study because both my parents had Alzheimer's. My mother was 72 when she passed away. My dad has been struggling with the disease for 13 years. So I have that unusual opportunity to be working with the doctors that are on the forefront of the research. They are giving me something that might let me hang on to my memories for much longer.
A major goal of the AHEAD study is to represent the people who are most at risk for developing the symptoms of Alzheimer's disease.
Recruitment of diverse populations into Alzheimer's research is a priority so that we can understand and address these health disparities that exist in Alzheimer's.
And if we don't participate, we run the risk of the treatment not benefiting us.
I'm in AHEAD study research because I have a family history of Alzheimer's.
3 out of 4 of my grandparents suffer from dementia.
Several of my relatives in the next generation have also started to have dementia-related issues.
I'm an AHEAD study researcher because I want to see a world without Alzheimer's disease.
And I'm committed to doing everything I can to make sure that my children don't have to deal with it themselves.
We have a unique opportunity to get ahead of this disease.
We're doing this for our grandchildren.
Help us get ahead of Alzheimer's.
Help us get ahead of Alzheimer's.
Ayúdenos a adelantarnos ante la enfermedad del Alzheimer.
Help us get ahead of Alzheimer's.
We will find a treatment or a cure for Alzheimer's disease, but not without your help.
Okay. Thank you, Steve.
Okay. Slide. Whoops.
The AHEAD study is enrolling healthy people age 55 to 90. If you are on the younger end, age 55 to 64, you must have one of the listed additional risk factors here. And if you are over age 64, you do not have to have the additional risk factor. So they'll just accept you because of your age, for screening anyway. You do need to have a study partner, so someone who knows you well and has 10 or more hours of contact per week with you, because we will ask questions about behavior, mood, functioning over time, and we need someone who is comfortable answering those accurately. One perk of the study is that if you are eligible to go through the screening process, you will learn your APOE type and also your brain amyloid PET scan results if you want to. There's also a small stipend, and if you don't live too far away, we can assist with providing lift transportation. And I didn't put this on the slide, but if you are interested in participating in the prevention trial, the AHEAD study, please go to www.aheadstudy.org and complete a pre-screening form. You can also email our study coordinator, Emma Brennan, at E as in Emma, B as in boy, 1321@georgetown.edu, and let her know you are interested, and she'll contact you and ask you a few questions to determine your eligibility for screening. So that is the AHEAD study information. And next I have some information about the ADNI study. Steve has a little video he's going to put up, a little clip. The ADNI study provides another opportunity for participating in research without taking a study drug. You can still be part of helping to move the science forward. It's a longitudinal non-treatment trial that has been refunded every 4 years since 2004.
Okay, my fault on this one. The ADNI video, I didn't have that one loaded up. I apologize.
Oh, that's okay. You can just type in adni.org and you can see a lot of information about the ADNI study. It's really been a landmark study to give us tons of information about it's how we develop the PET scans and some of the blood tests. So it's a very worthwhile study. It is a study where you will come in based on whatever group you're in, either cognitively normal, mild cognitive impairment, or Alzheimer's. You don't, like I said, non-treatment. It's just a longitudinal follow study. We see you annually or biannually visits for cognitive tests, lab work. It does require a spinal tap and also brain MRIs and PET scans. So if you don't mind doing those things, it's a great way to give back and help us find new therapies. ADNI 4 is going to be starting up next year. Like I said, it keeps getting refunded. I've had patients that have been in the study like 12 years, so it's really worthwhile. The ADNI inclusion criteria, which is the next slide. You can't have any serious neurologic disorders. If you're in the cognitively normal group, such as seizures or stroke, you must be medically stable and cancer-free for 5 years. You need to have a study partner and to be able to undergo MRIs. And you can't be on blood thinners because of the spinal tap, and you have to be a native English speaker. And they're really looking for people aged 55 to 90 that can enroll, but the cognitively normal group must be at least 65. A lot of times people with mild cognitive impairment and Alzheimer's would want to be more in a treatment trial than a non-treatment trial. But sometimes if people can't qualify, then they would want to be in the ADNI study. So the next slide is on, I said I was going to mention about the Alzheimer's Prevention Trials web study. So you can engage in research even from your couch. I want to highlight in particular this study, which is sponsored by NIA and the National, the Alzheimer's Therapeutic Research Institute, ATRI, and 2 other institutions. It's an observational study for volunteers aged 50 and over. It takes about 20 minutes to register, aptwebstudy.org, and they'll ask you to consent online, and then you complete 2 memory assessment measures. Once enrolled, you complete online memory tests every 3 months, and then testing takes about 20 minutes. And they do monitor, so if you trigger at high risk, you will be invited to join a study to be evaluated more closely, and that is called the TrackPad study. So it's another study where they sort of will monitor you and then offer you treatment trials if they feel that you qualify. So really good thing to be a part of, the APT web study. Next slide is some other registries, other ways you can be involved and stay informed. The first 3 are registries where you can read about them all online. And the bottom one is the National Institute on Aging website for education and information about trials. So all great ways to contribute. And the last slide is just some resources that could be helpful. Of course, clinicaltrials.gov, listing all the trials, healthybrains.org, providing information about brain health and tools and resources to reduce risk for brain disease, and now.org, GeneMatch. It uses genetic testing through free cheek swab kits. I know that stopped a while during the pandemic. I think they're back running again to match volunteers with research opportunities. So they look at your genotype on the cheek swab. I don't think they tell you what it is, but they do offer you, if you can match with a trial that's looking for that genotype, then you may be offered research opportunities. You must be cognitively normal, age 55 to 90. And finally, you can, again, find us on the web at memory.georgetown.edu. We have information about all the trials on the website, and you can find our educational newsletters there. For clinic appointments and research information, you can call our program coordinator, Carolyn Ward. Her number's there, or by email, her cw2@georgetown.edu. If you are interested in research, she'll put you in touch either with a research assistant or a coordinator, and she can also enter you into our database, consent you over the phone and put you in our database. And you can reach me, Kathleen Johnson, at K as in kite, B as in boy, J as in jump, KBJ, the number 5 at georgetown.edu. So thank you. I hope you had a big cup of coffee before you came and you're still awake. Thank you for attending. And Steve, I'm happy to try to answer any questions that people may have.
Okay, well, thank you. And I am really impressed at how you did that today on the phone. That's not easy. But let's dive into the questions, because we've got some really good ones here for you, Kathleen. Okay, so the first one says, I'm happy to attend this conference. It's a privilege to hear you speak. My husband took part in the amyloid beta blocking clinical trial at Georgetown 4 years ago. I'm wondering, would you know if amyloid or tau tangles cause the brain to shrink? Also, could you speak about lysome storage in dementia?
Interesting. So I'm wondering, is this Michelle?
It is Michelle. Michelle Lane. Yes.
Hi, Michelle. Oh, yes. Thank you so much, Michelle, for all your contributions, you and your husband. We just loved having you in the trial. And, you know, you were a big part of moving all this science forward. Amyloid or tau tangles, they can both contribute to the shrinkage in the brain, the atrophy, the neurodegeneration. It's just, I'm not a scientist. I can't explain the science behind it, but I know that that buildup of proteins does cause neuron death and dysfunction, and that's part of why certain areas of the brain don't work anymore and they start to shrink. So I think both of those probably contribute. I don't know enough about lysome to comment on that. If you want to email me, Michelle, I can look. I can talk to Dr. Turner and get back to you on that, or find more research on that for you. It's a good question. Does that answer your question?
Well, we'll do our best, but she can get in touch with you.
Yeah.
Diane asks, to what extent do SSRIs worsen or improve cognitive decline?
Okay.
And
that's a good question.
Just for folks to SSRIs are what?
Okay, so SSRIs are selective serotonin reuptake inhibitors. So they help balance the serotonin in the brain. I would say probably 70% of my patients take an SSRI. You know, when people have memory problems, they can get a lot more anxious. They can have a lot more difficulty in situations that are new. And it's very frustrating to not be able to call on your memory to do things. So we see a lot of patients with apathy, anxiety, depression in the early stages, and also throughout not everybody, but you know, it's a fair amount. So we do often give one of the SSRIs, which could be sertraline, Zoloft, also called Zoloft, Lexapro, also called escitalopram, or Paxil, also called paroxetine. I tend to not give Paxil as much, more the other two. And I can't say that they actually help confusion at all or help memory, but I think they do help in making people more relaxed so they don't get as upset about things. They're maybe less reactive, less volatile in terms of getting upset about things. And when you're not as anxious, you can attend to information better. So you can take in that information better and have a better chance of keeping it in. So I can't say they worsen or improve memory, but I think they can help just that everyday functioning. Your energy is a little better, your mood can be better, and also attending to information can be better. So I think that's how they help. But of course, we want to use them very judiciously, start slow, and small dosages, go slow, slowly increase. You sometimes have to take them for many weeks before they help if your symptoms are subtle. But I think they can be very helpful. And of course, you always have to do it under a clinician's judgment and also looking for any side effects. But I hope that answers your question. I guess overall, I think they can be very helpful.
Okay, great. Okay, Diane asks, yesterday, Dr. Rabin said that the timeline is 10 years from onset of Alzheimer's to death. That is terrifying. You said 20 years. That is a little more comforting. My husband tested normal for MCI, mild cognitive impairment, but I noticed, and then the psychology noticed, he wanders when he tells stories, and the neurologist found early signs of Alzheimer's in a PET study. So what do you think the timeline is?
Okay, that's a really good question. And it is really highly variable. If somebody had a very aggressive course, which we really don't see very often, it could be like 2 or 3 years. But most people, I think Dr. Rabin mentioned 10 years, because when someone comes to me and they have functional decline, so they can't do their finances anymore, they can't navigate They can't keep track of their appointments on a calendar, those kinds of things. So the beginnings of functional decline, that's when we really say, you know, maybe the beginnings of Alzheimer's, memory loss leading into early functional decline. Those years are kind of when the clock starts. And at that time, what we usually see when they have functional decline is about 10 years, but it is really highly variable based on other people's health. You know, we really can't predict how fast it's going to go. Usually the amount of change you've seen in the past year might predict how fast, you know, it might be in the next year. So if it's really, you're seeing a lot of changes really quickly, then that might indicate that the disease course might be a little bit faster. But most of the time, it's usually about 10 years when we start to see functional decline. But mild cognitive impairment can last anywhere from 2 to 20 years. So that can be really a long period of time. It can be from other things that are aggravating your brain, you know, sleep apnea, you know, COVID, all kinds of things can aggravate your brain. So medication. So I think that the timeline is really variable. What I said by 20 years, meaning that we can see the amyloid in the brain for years before they have memory problems. So that graph that I showed, or that chart, was really preclinical. That means changes in the brain and mild cognitive impairment and the 10 years of Alzheimer's. So that altogether would be 20 plus years usually.
Great.
I hope that answers the question.
Yeah. Yeah. Okay. Nancy has a question. Should Donna, how do you pronounce the drug? Donepezil?
Yeah, donepezil. Donepezil.
Okay, sorry. Should donepezil be discontinued after the dementia has progressed and no evidence is helping any longer? And also, Nancy, take a look in the Q&A section, because Michelle has shared some insights on different drugs, but her question is specifically, should it be discontinued after the dementia progresses?
Well, that's really a conversation you need to have with the prescribing doctor. I feel like if somebody is on donepezil, but they're really not having much quality of life, or they're not recognizing people, or they're not, you know, there's no discernible, you know, it's not helping in any discernible way, then yeah, you could stop that. That's fine. I mean, it's really up to, you should have a clinician talk, you know, together to see how they're doing overall, what disease stage they're in. And that's, you know, it's okay to not take the medications. It's okay to stop them. You know, it's really just depends on, obviously it hasn't, you know, the disease has moved along far enough where it's not really doing anything. So, you know, it's fine to stop it. Oftentimes if people early on are taking donepezil and they think, you know, because it's a progressive illness, they still see decline, the family will say they're declining, it's not helping, they'll stop it. And then I do often get a phone call a few months later where they'll say they seem like they've gotten worse. And I don't know if that's because of stopping the medication or just because the disease is progressing. So it can be really hard to tell with these medications if they're helping. So that's a really good question. And it's fine to stop medications and see if they're not helping. If you don't think they're helping, it's fine to talk to your doctor and agree to stop using them.
Well, actually, Leah has a question, but she also has an interesting insight on donepezil. Leah says, my wife was diagnosed with MCI, mild cognitive impairment, 5 years ago, and has been on donepezil since then. Her memory loss has been gradual, and she can still do many things on her own. She can be left alone all day if needed, and she appears okay in most social situations. She's 85 years old. Does this slow progression indicate that she is less likely to develop seriously debilitating dementia? How long does it typically take for MCI to become Alzheimer's or another dementia?
Yeah, good question. Well, like I said, it's really variable. It's just highly variable, especially in an older person. If they have really slow changes, I think it probably is less likely that it's going to turn into anything very quickly. But it's just really, I can't predict. It's just really very difficult. If the last year has been slow, not much change, that's a good indicator that the next year might be also slow and not much change.
Okay, great. This is a good question. Anne says, when someone is told their brain is shrinking, what does that mean?
Yeah. Well, it's just like when you get older and your muscles shrink a little bit. The same thing with your brain. It gets a little bit smaller, and that doesn't necessarily mean that it's not working as well. You can have some atrophy and still function and do really well, but oftentimes we do see people who have Alzheimer's who also have atrophy or brain shrinkage. So it often can be a sign of the more disease, the brain not working as well. So shrinkage itself doesn't necessarily give you a diagnosis. It's more in combination with the clinical symptoms.
Great. Okay. Diane asks, can someone be part of the clinical study if he is in the very early stages of MCI and already taking some of the meds to slow memory loss?
Yes, that's fine. A lot of clinicians do prescribe the cholinesterase inhibitors, donepezil, galantamine for MCI. It's not technically, FDA isn't approved for it, but we don't tend to prescribe it for MCI because we tend to go more by the regulatory recommendations. But a lot of clinicians do prescribe for MCI, and some patients feel it helps. Most of the MCI enrolling studies do allow cholinesterase inhibitors. You would just need to be on a stable dose for 8 to 12 weeks before entering a study. Otherwise, if you just start a memory medicine and then you also enroll in a trial and your memory changes, we won't know if it's because of the memory medicine you just started or the drug you might be getting in a trial. So we are required to have people on stable medications to not make any medication changes, especially memory medications, for at least usually 12 weeks before they enter a trial. So yes, if your husband has MCI, we would love to talk to you about clinical trials and see if there might be something he's interested in. We would be adding something experimental in addition to his memory meds. He would stay on all his current memory medication.
Great. Joan asks, are there memory disorder centers similar to Georgetown in the Pennsylvania, New Jersey, or New York area?
The short answer is yes. The long answer is you'd have to look online and look for memory centers. So yes, there are. Usually in each state there's at least one memory center that offers clinical trials.
Okay, and I don't want to cause unnecessary contact with your program, but if someone from out of the region contacted your program, do you have sort of sister programs you might be able to assist them in finding something?
Well, we're part of government funding, which is called, we're part of the Alzheimer's Therapeutic Research Institute, ATRI. So if you look up Alzheimer's Therapeutic Research Institute and look at trial centers, you would be able to find that would also locate them, places that are near you, or ADRCs, which is Alzheimer's Disease Research Centers. So if you looked up Alzheimer's Disease Research Centers, the government does fund. We are not an ADRC yet. We might be down the road. I know Hopkins is an ADRC, but they have social workers. They have, they get more staff, and they offer a lot of trials as well. But if you can always email me, Leah, was it Anne or Leah, whoever has this question, you can always email me and I'm happy to try to find a center for you. I know UPenn has a pretty big center, and I don't know off the top of my head what the other ones are, but there certainly are other places available.
Okay, great. Do you have many people in your programs that are from out of the area and that might travel to participate?
We do have some people from Delaware and occasionally someone from Southern Virginia, but usually you should be within a couple of hours of a trial center. I think it's better if you are within a few hours, because sometimes you might have to come back for additional testing or for another MRI scan. For the safety issues that are involved, it's good to be pretty close. But some of the treatments, like the nicotine patch, that's only every 3 months. So the trip down isn't that often. So those types of studies that are less burdensome with trips to Georgetown they tend to work better for people who are out of state. And also, in the winter, trying to travel, sometimes you have to reschedule appointments if there's difficult to travel. But we work around it. So occasionally we do have people for more than 2 hours away, but I would say generally speaking, people are within 2 hours.
Great. And I'm glad you brought up the nicotine patch, because Diane asked, what about the advisability of an individual patient just trying a nicotine patch on their own? So sort of, can you hear me? Uh-oh. Kathleen?
Yes, I can hear you now. So I'm sorry about that. The nicotine patch, I wouldn't try that on my own. I would do it only in a controlled setting with clinicians that know the side effects and the risks and can respond to any new situations that would come up. I wouldn't just try it out of the blue, because it can have side effects, and we don't want to aggravate any underlying medical issues. People who enter our clinical trials are screened very carefully. We look through all their records. We look at their other medications. We communicate with their doctors. So it's a much different setting than just trying something. And we don't know if it works. So I wouldn't just out of the blue try something because you think it might work. It's likely that we would have to we determine if something works by how they do on cognitive testing and things like that. So I wouldn't recommend just trying something not in the setting of a clinical trial.
Great. Okay. Richard says, with an HMO, what to ask an HMO neurology department to get more attention, consideration to change the family's health insurance to find better or more attention. So any guidance related to that?
I'm not sure about the question is about.
Well, I think a member of an HMO and they're not getting the attention related to the loved one's memory disorder, and they're considering changing insurance from the HMO to get better attention. This also is an opportunity too for people in the audience, if you've got experience with HMOs or insurance, to help Richard, throw that into the comments. But I wanted to share that with you just in case you could give Richard any insight on insurance coverage.
Well, you don't need insurance to join the clinical trials program. Everything's paid for by the sponsor. And usually HMOs can have very good clinicians and neurologists. And so I'm wondering, is there something in particular you're looking for that they're not providing? You could, if you're with a clinician and you want someone with more, that you could look more for a neurologist in that HMO that has more specialty in memory loss, or you could bring information to your clinician or your neurologist and ask questions about the things that you'd like to have ordered. I think working with the doctor that you have now is usually a good place to start. If there's specific things you think aren't being done, you should query, why they aren't being done, or if your loved one is appropriate to have the test done. A lot of the things I talked about are things that we do in clinical research, but they're not covered by any insurances. They're done in the research program. So does that answer your question?
Yeah, I think so. And Richard, another thing to think about is there's a profession out there called patient advocates. You might do a search for that online and interview a few patient advocates that have experience in dementia and Alzheimer's. These are individuals that can work with you and your medical providers to make sure that you that somebody is advocating for the best possible result. Sometimes it's just knowing how to navigate this wacky medical and insurance system that we have. Okay, let's see. Mikey says, can a couple participate in the AHEAD study together?
Yes, we do get those questions sometimes. I would not recommend it. I would recommend one person at a time. And the reason is because if you were to go through the screening process and you found that you had elevated amyloid and you were randomized to coming in every 2 weeks for the next 4.5 years to get your infusion, that's a lot of trips to Georgetown. I mean, people like us, but they don't really like coming every 2 weeks that much. So I would say one person participating in the study for a family is really enough. And so you could participate if you go through the screening process and you don't qualify, then your wife could go through the screening process to see if she qualifies. The other thing is you need to have a partner. So if you're both in the study, that doesn't work out as well because the partners are there really a lot. And also the types of questions that we ask, they can kind of be not as accurate if you're both participating because you know the types of tests and questions. So I think it's better if only one family member does start out in the beginning. I'm not saying it's not possible, but I really think it's not a great idea.
Okay, great. What is the difference between, Francine asks, what is the difference between white matter disease and Alzheimer's disease?
Okay, so white matter is that area of the brain that sort of transmits information from one cell to the next. So white matter disease can often be affected by vascular changes, age, or if you've had hypertension for a long period of time. We often see white matter disease in people who are older. We don't really consider that, I guess, related to Alzheimer's disease. That's just a finding that's on a brain MRI indicating that people have had either changes with aging or because of the other illnesses. It doesn't really indicate specifically Alzheimer's disease.
Okay. All right. And I knew the brain shrinking question was going to bring up a few other follow-ups, but Rose Molina asks, at what age does your brain start shrinking?
Well, I mean, we do get people who are in their 80s and 90s who have normal brains. It doesn't say shrinkage. So it's I can't say exactly. I actually don't know the correct answer to that question. I think it's really, I see some people who are in their 50s that have had some shrinkage, and I see some people in their 80s who it doesn't say shrinkage. So it's really variable.
Got it. Let's see. Sam says, can you talk about the recognition study for drug that attempts to slow or block tau development? I was not eligible for the Trailblazer because I did not have enough tau, though I am amyloid positive.
Yeah. Hi, Sam. How are you? I know Sam. Thank you, Sam, for volunteering. I'm sorry we didn't find a match for you yet, but I know Bridget's going to call you because she mentioned you the other day for the TrackPad study. So I don't know the one that they're doing right now, honestly. I don't know the tau study that they're doing.
Okay.
I'm not familiar. I know Recognition has trials, but I don't know which ones they're doing right now. We do have an anti-tau study right now called the Janssen study, and that one is looking at tangles. So if you didn't have tau last year, probably unlikely you're going to have it this year. So I don't know that you would qualify for that one either.
Okay. Well, number one, this just speaks to your fan club and all the folks that are here that you know, and the fact that there are so many studies going on, and that leads to another trial, that a question that Claire has, and Claire says, are there any trials locally for people with moderate disease?
Not that I know of. All of the sponsors are tending to go toward early enrollment. The papinimab study that I mentioned earlier is enrolling people with a minimum of 17, but they have to be pretty mild to early moderate in terms of functioning. So unfortunately, over the years, they just think a lot of the things that we've tried aren't working because they're starting them too late. So we don't really have anything for more moderate illness right now, and I'm sorry about that. I wish we did. A lot of times things they look at for moderate disease are more behavior medication. We may have something down the road. We are going to have a study next year, which is called the Levine trial, and that is more for people who are very severe and who are on hospice, and it's going to be looking at a cannabis type product for mood and comfort. So that's something that is, I know she asked about moderate, but that is another study. We are trying to grab onto some other studies that might be helpful for other phases of disease. And that one's going to be a short 12-week study for people who are really in palliative care and towards the end of life. So right. I'm sorry, Claire, we don't really have anything for more moderate people.
Okay. And then Sheila asks, does the chronological age of a patient have an effect on how fast the disease progresses?
Well, I can tell you that a lot of people think that people who get early onset, they think that the disease goes faster, but I think it really is more 10 years or more because of the losses. It seems faster because of the losses that they have. A lot of them might have been working and having busy schedules and driving and a lot of things going on. And then when they have to stop all these things, or if they stop doing them because of their cognitive changes, it does seem like the disease is moving faster, but and it might a little bit, as opposed to someone who's already retired and not working, and then they get the disease. It doesn't seem like they have as many life changes. They still do a lot of things they've always done, but it's just really variable. I can't accurately answer that question. I'm sorry.
Got it. And it looks like we got about 5 minutes, so I think we can get through the rest of the pile of this these questions here. And thank you to everybody in the audience for these great questions. This is fantastic. Okay, so let's see. Rocio says, besides ARIA, are there any negative effects or consequences related to reducing amyloids in the brain?
You can have, some other types of reactions. You can have nausea, those symptoms that I listed, but and the ARIA being both the microhemorrhages and the vascular edema, so the fluid shifts and the pinpoint hemorrhages. I don't know of any. I don't know that there's been anything reported that is adverse from taking those drugs. Especially in a monitored setting. The big thing is that, if they do become available, there has to be, the providers have to be educated that giving the drug also means doing MRI scans at the time points that are necessary to really monitor for changes that are called ARIA. So, if we monitor them, we can act accordingly based on the severity. If they aren't monitored, that's when the side effects can occur. So, or that's when more serious side effects can occur. So that's really the big thing, is the monitoring.
Great. And Martha has we have another question on brain shrinkage. Martha says, I understand the brain does not shrink. Instead, the brain possibly contains more tau.
Yeah, I think it does have more of the proteins and the plaque in there, but the changes do cause a little bit of shrinkage. And I don't know technically, like I said, I'm not a scientist.
Okay.
That's a good question. I don't feel really that I can accurately say that.
Let's see.
Yeah.
Courtney asks, does glucose play a role in the disease or in diagnosing the disease?
Well, there's a lot of, not really for diagnosing. We do think diabetes is a risk factor, but we are looking at therapies. We did intranasal insulin to try to reduce sugar levels and make a more, in the brain to try to protect the hippocampus, the memory center. So we think there is probably some role in especially in aging, but I don't know enough to say specifically, what that role is for Alzheimer's type dementia. So certainly good glucose control is good for all of your organs, including your brain, and reducing hyperinsulinemia or the rush of insulin that your brain gets if you have, elevated sugars. Those controlling those factors helps protect the brain, and I think more research needs to be done.
Great. This is Jerry Lee has a very interesting question. Any suggestions on how to get a feel for whether or not memory and other low functioning issues are related to PTSD and depression? This individual lost a spouse of 57 years on their anniversary unexpectedly, and then adding the COVID isolation rather than dementia or physical medical issue. This was a question that came up yesterday too.
Not sure where to start with that one. I mean, certainly depression and apathy can sometimes be a sign of go along with memory changes. I don't know that we are studying that. PTSD is one of the arms of the ADNI study. We have enrolled people that have PTSD. I don't think it's enrolling anymore, but we enrolled about 5 or 6 years ago veterans with PTSD. So that is something that's being studied right now. And is the question, I'm sorry, I can't see it in front of me, memory and low function issues, was the question contribute to dementia? Or
I think some of this is, it's sort of misdiagnosing Alzheimer's and dementia due to PTSD, depression, and other factors.
Yeah, so that goes back into other factors that can contribute to getting at the accurate diagnosis. So trying to treat PTSD and depression as much as you can to try to see if that improves the memory as well. So, for example, neuropsychometric testing is a good way to sort of get a baseline about people's memory and thinking. So people who really early on trying to discern what's causing what. But if someone's depressed, then they don't attend to information. So you're not going to get accurate testing results from neuropsych testing if that long, different areas of the brain, with all the tasks that you do with visual spatial testing, if you're visual spatial testing and working memory testing and those kinds of things, you're not getting accurate information if someone is depressed. So trying to treat those things first to be able to accurately tell if someone has a dementia starting. But it's really looking at the big picture over a long period of time to see if the function is declining. That would be more of an indicator of there is probably some kind of pathologic dementia or early dementia going on.
Okay, well, we got through a ton of questions, and there's just a handful that are in the queue, but we've overstayed our time. I am so impressed at Kathleen at how well you did presenting today, given the technical difficulties, and I thank everybody for their participation in the program. And I believe we are going to take what looks to be, there's Dan. Dan, how we've got a brief break, correct? And I'm going to play some of the sponsor videos for us.
That's correct. I think we're going to take a 5-minute break. Yes, go ahead and play those sponsor videos, and then after the break, then we will introduce our next presenter.
Okay, which I'm really looking forward to that one. It's with Leanne. It's what I don't have the agenda in front of me right now, but what's our topic in the afternoon?
Our topic in the afternoon is meaningful music, and we have Leanne Belasco with Levine Music, which is one of Washington, D.C.'s preeminent music schools and music education. So we will introduce her formally after our break.
Okay, great. Well, here we go. And again, thanks to our sponsors. And here we go.
What's happened in Virginia's nursing homes is an unacceptable tragedy. But chronic problems that plagued nursing homes long before COVID still exist today, like understaffing and poor infection control. It's time to put the safety and well-being of nursing home residents first. Virginia needs state standards that require nursing homes to have enough adequately trained staff to care for residents. Tell your state lawmaker to support nursing home reform. Virginia seniors deserve better.
For 55 years, we've been known as Goodwin House, this really trusted brand, but most people think of us as a place that you have to move into. They don't think about all the services we provide or all the ways that we can engage with you as an individual that are well beyond housing. And so Goodwin Living allows us to be much more comprehensive, to expand, and allow us to have so many other conversations.
We have this uncanny desire to do more. We refuse to stop.
There are just so many opportunities for everyone as we look to touch each and every senior's life out in the community.
I just like to say that we are honored to sponsor it this year. We have sponsored it for decades. Our founder of Graceful Care, Pat Williams, is one of the leaders and thought leaders for this conference and has been for a very long time. She started Graceful Care in the mid-90s and was she named it after her mother, Grace. They're the Graceful Care. We kind of played on that. And we're a small, intimate family run organization, and we usually know the people that we're hiring. And I like to say that it's that our caregivers are the sons and daughters for when the sons and daughters can't be there. That we're there to get everyone to their doctor's appointments and make sure things are done and that healthy meals are made for them, and the things that normally you would do around the household that just need a little bit of helping hand. We're there for you and have been doing that for decades. I just like to say,
with Synergy, amazing things happen. Even if they've forgotten the recipe, it's the feeling they'll remember. Some things don't have to change, like your sense of style. A gentle nudge is all you need to move forward. We believe companionship fills more than time. The Synergy Effect, brought to you by Synergy Home Care.
What's happened in Virginia's nursing homes is an unacceptable tragedy. But chronic problems that plagued nursing homes long before COVID still exist today, like understaffing and poor infection control. It's time to put the safety and well-being of nursing home residents first. Virginia needs state standards that require nursing homes to have enough adequately trained staff to care for residents. Tell your state lawmaker to support nursing home reform. Virginia seniors deserve better. What's happened in Virginia's nursing homes is an
Okay, well, thank you so much for our sponsors there, and make sure you check the exhibit hall. I know that that's there. Well, Dan, here we are, the second half of our second day, and I think you're gonna load up that program, so I am gonna duck behind the curtain again.
Okay, thank you, Steve, and thank you to Kathleen for that very informative and impactful and hopeful presentation regarding evaluation and treatment and diagnosis, and there's a lot of hope. There's a lot to be hopeful for. So we're going to shift gears a little bit, and we are going to introduce Leanne Belasco, who is the Director of Music Therapy at Levine Music in Washington, D.C. And Leanne is the Director of Music Therapy at the Levine Music. Levine Music is DC's preeminent center for music education, where children and adults can participate and find inspiration and joy through performing and listening to and participating in others' music. Leanne earned her BS in music therapy from Duquesne University, and her MS is in special education with an emphasis in autism spectrum disorder and severe to profound disabilities from Johns Hopkins University. She's worked extensively with older adults with neurological diagnosis, such as Parkinson's disease, stroke, Alzheimer's disease, and other dementias, as well as children and adults with intellectual, cognitive, and developmental disabilities. In her presentation today, we will explore ways in which music can impact and assist the daily lives and emotional well-being of those with dementia, their caregivers, and all of those impacted by Alzheimer's and dementia. So without further ado, I am going to turn it over to Leanne. Welcome, Leanne.
Hello, thank you so much. It is such an honor to be here with everyone, and I am so excited to be a part of this conference. And thank you all for being here. And as Dan said, my name is Leanne Belasco. I'm the Director of Music Therapy at Levine Music, and we are in DC, Maryland, and Virginia. And we serve people from all walks of life. And I'm hoping today that we can talk a little bit about music. But since it is a music presentation, I would be remiss if we didn't start with some music as well. So this is one of my favorite songs to start a group with, and I'll tell you why when I'm finished. And I invite you all to sing along if you know the words. And if you don't, I invite you to move how you feel comfortable or just listen and think about how your body and how your mind responds to the music as we sing together. There's a bright golden haze on the meadow. There's a bright golden haze on the meadow. The corn is as high as an elephant's eye, and it looks like it's climbing clear up to the sky. Oh, what a beautiful morning. Oh, what a beautiful day. I've got a wonderful feeling. Everything's going my way. And I want to do one more verse, and this one is my favorite. And the words say, all the sounds of the earth are like music. All the sounds of the earth are like music. All the sounds of the earth are like music. The breeze is so busy, it don't miss a tree. And an old weeping willow is laughing at me. Oh, what a beautiful morning. Oh, what a beautiful day. I've got a beautiful feeling. Everything's going my way. Oh, what a beautiful day. And so I like to start with this song because it talks about thinking about the beautiful things in life and having a positive outlook. And so I'm hoping that our time together today can provide some opportunities for talking about that light and that positive impact and inspiration of music for our loved ones. And so we'll hopefully have time to do some music throughout as well, just to provide you with some examples too. Just a little bit about my background. I have been a board certified music therapist for over 15 years, and I have worked with many different groups of people and their families, including quite a bit of work with adults with memory disorders in both group and individual settings. And I, even 15 years later, am continuously amazed at the connective power of music with our loved ones, no matter what stage of life we're in. If you think about it, we have music in our lives before we're even born, with the rhythm of our mother's heartbeat and womb sounds. And so music is part of our lives from the very beginning until the very end. And every important stage or event throughout our lives is connected with music. So we're going to talk a little bit about that today, and which begs the first question of, why music in the first place? And why is it that we use music for individuals who might be experiencing different stages of memory loss? And as music therapists, we are trained to harness the aspects of music like melody, rhythm, and harmony to help affect positive change in our clients or in our patients. And so we are looking to see how we can help individuals grow or recover or heal and improve their quality of life through engaging in music, whether that is through playing or singing or listening or moving and accessing those musical memories throughout our work together. We aren't, as music therapists, looking to create a room full of composers or to create a room full of professional musicians when we're together, nor are we performing for individuals or groups. There are many wonderful, wonderful musicians and performing artists who bring amazing music to different communities, which is absolutely amazing. What I want to talk to you about today is how we experience music together with our clients in a very active and reciprocal way and intentional way. And so many times we are able to involve loved ones and caregivers and team members in the therapeutic process. And so we love to provide tools and strategies for how to keep the music going when the music therapist isn't there with our loved one at any given time. We would love to be everywhere at all times, but that's just not feasible. So we like to have those carryover strategies too, of how we can take something that we so naturally engage with our families and with our friends, and how we can apply that to something that can really provide a benefit for our loved ones, no matter what they're experiencing. So Steve, if you would pull up that slide again, that would be great. I just wanted to highlight the benefits of music for different ages and stages, just to lay the foundation for why it is that we do use music. And the first thing is the social connection piece. Music is inherently social. We experience joy when making music together. And the history of music has been, an engagement of all civilizations since the beginning of time. And it's been a social mechanism to bring people together for rituals, for healings, for celebrations and ceremonies. And so active music making together really makes a big impact on our social connectivity with others. We also use music for physical activity. If you think about exercise and physical health, music helps us to exercise longer because we're engaging our brains in something pleasant and preferred. So we can do more of a task for longer, maybe with more repetitions or more miles or whatever we're doing to exercise. And this also helps us with our patients and with our clients when we're really looking at physical rehabilitation or improving mobility and helping getting people moving. I'm not sure how you all responded to the opening song, but I'm hoping or guessing that some of you were probably moving your bodies, whether you were swaying or tapping your toes. And the rhythm of music really helps promote that physical activity and gets our muscles moving as well. There's also research that shows that music can help us get better and longer sleep with music assistance. Also, physiological regulation is a big thing that we work on with music in a variety of different settings. So we can work on breathing, and we can work on regulating things like heart rate or respiration or blood pressure and oxygen saturation with different music interventions, and using the rhythm and structure of music to help change levels of our physiological functioning. And so we have an opportunity now. I would like to just do a little bit of a breathing exercise with everyone, because it's always a good idea to take a second to breathe. And so I just wanted to demonstrate a little bit about how we might use music to support something like breathing. If you work with an individual and think about, or even just think about how you're sitting and breathing, and notice, is your breathing regular, or are you breathing quickly, or do you take shallow breaths? And so we might use music to help support the breathing process by providing a rhythmic framework to help us organize and slow down our breathing, or to enhance and make our breaths bigger. So what I'm going to ask you to think about is to breathe in for the count of 4, and then breathe out for the count of 4. And so we're going to start together and get ready to breathe in, 2, 3, 4, and then out, 2, 3, 4, and in, 2, 3, 4, and out, 2, 3, 4, and we can just keep going. So all the music is doing is providing a framework for you to work within to keep things very organized. And whether or not you realize it, you're taking the cues of the music. When I go up the piano, you're breathing in and out as we relax. And then if we have someone who might be working on a little bit more of lung capacity, where we might want to breathe in and then hold and then breathe out. So we'll start by breathing in, 1, 2, 3, 4, and hold, 2, 3, 4, and out, 2, 3, 4. One more, in, hold, and out, 2, 3, 4. So that's just a simple way where we might work with someone on to helping with breath support and just regulating our breathing. That also assists with relaxation and pain management. I've worked with a number of individuals post knee surgery or post some kind of surgery where they're working on physical rehabilitation, and the work is really hard. And so having those dissonant sounds where I know it's hard work, but we're going to support that. When you were holding in the breath at the top, the music sounded less comfortable because we know that we're validating what you're feeling with the sounds of the music. So that's one way that we can use music for that physiological regulation piece. Also memory recall, which we'll talk about in a few minutes, and then positive mental health and mood. Listening to music releases dopamine, which is our feel-good chemical in our brains. And so it automatically helps us with mood regulation and mood improvement. And at the same time, we're able to reduce stress with music because it also reduces the stress hormones by lowering our levels of cortisol. So there are a lot of different benefits, no matter where we are in whether what age or stage we're in. All of these are benefits for music. So if you go to the next slide, please. I just want to take a few minutes and talk about a few of the highlights for why we use music therapy for individuals with Alzheimer's and dementia. And the first thing is that musical memory is preserved the longest. So oftentimes musical memories from our adolescent years are the most firmly embedded in our brains. And I would imagine that we all have those songs that when we hear them, we're immediately transported to another time and another place. We often use this music to connect with our loved ones and to then access those deeply rooted memories. And so we ask, as music therapists, we ask for those music preferences and ask families for those songs that we know that our loved ones can connect the most to, and then grow from there as well. Music also has improvement in mood and quality of life. There was a study in 2020, the AARP did a music and brain health survey of over 3,000 adults over age 18. And those who engage in music making or music listening are more likely to report overall health as being excellent or good. And listening to music also has that positive impact on mental health and well-being, which is so important, especially over the last few years as well. Music can also reinvigorate a sense of identity and self, whether you or a loved one was a musician in the past or sang in a church choir or just was an avid music audience participant or a musical theater aficionado. Reactivating that sense of self is so important to improve our mood and our self-esteem and our feeling of purpose as well. And it also restores personal connections. We love incorporating songs that have a connection for our loved ones so that we can help strengthen that bond between individuals and family members. And we've seen such positive impacts when we have individuals engaging in music with their caregivers. And then it becomes a shared experience, which is so powerful. And we see so much blossom out of that starting point of connecting through making music together or listening to music together as well. And we'll talk in a few minutes about how it can assist caregivers in areas of daily living. But I also want to remind you that music also provides personal benefit for caregivers. And think about how you use music in your own life and make sure that you're carving out time for stress relief and relaxation. And music can help with that. And that's a big reason why we also encourage our family members and caregivers to engage together in music with us, because there is such a benefit for caregivers to be active in this process and to experience the music as well. Go ahead to the next slide, please. And so I'm going to spend some time for the rest of our time together talking about ways to engage your loved one or your residents or clients. And those are the 6 main ways that I want to talk about today, is through singing, through moving and dancing, through pairing music with activities of daily living, through listening, through playing and learning, and through creating playlists to support routines. So you can take down the slides, Dan, and because we're going to go ahead and, or I'm sorry, Steve, I see Dan's name on the screen. So we are going to spend the rest of our time making some music together and talking about the different ways that we can actively make music together. And so the first one that was on the list was sing. And it doesn't have to be professional quality. It's the fact that it's your voice and that you're making music with one another is the part that matters. And so think about songs that you've shared together in the past and sing with your loved one. And oftentimes we'll see individuals who may not be verbal communicators or we might not have a conversation with. We'll see them sing along with familiar songs, or we'll see them mouth the words to familiar songs because those musical memories and those lyrics are still there. And so we're really trying to connect with those pieces of the person and bring that out so that we can reconnect through music. Also, even if we don't immediately remember lyrics, we can sing with just singing a syllable. We can just hum along with the song as well. And so I brought one song that's a great way to do this. And this, we'll just do a little bit of it just so that you can exercise your singing a little bit on your end. And this is Brown Eyed Girl. So this is a great one that you can also use, that we can just sing la, la, la throughout the song if you'd like. And here we go. Hey, where did we go? Days when the rains came down in the hollow, playing a new game, laughing and a running, hey, hey, skipping and jumping in the misty morning fog with our hearts a thumping, and you, my brown-eyed girl. You, my brown-eyed girl. All right, are you ready? Do you remember when we used to sing sha la 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 ti da? Sha la 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 ti da, la ti da. So that's a great one that even the chorus doesn't have a lot of words, but we can just engage in the music together. And maybe that's a song that your loved one grew up listening to, and maybe it's not, but it's also a fun one to engage with together. And there are many, many songs that have those types of choruses or lend themselves to just humming along or singing a syllable along with it. And if we don't immediately recall the lyrics of the chorus or of the verses, by the time the chorus gets there, we can jump in together and join our voices together in some way. Another way that we like to engage in music with one another is with listening. And listening can help us in a lot of different ways, not only like we talked about before with stress reduction and mood improvement, but it's also an opportunity for us to help with orientation to time and space. And so I would encourage you to find songs that is not only preferred music and shared music that you can relate to together, but music that might reflect the season or might reflect meaningful events on the calendar, and talk about what you're listening to. Something that might seem very passive, like putting on headphones and listening to music, can be turned into an opportunity for connection and for reflection and for conversation. Even taking something like What a Wonderful World and listening to it together, if we don't want to sing it together live, and then talking about all the things that are wonderful in the world, or looking out the window and seeing what we see to help really ground someone, and use the music as a point of connection where we can bring people together and also help impact our orientation to time and space and connectivity with one another. The other thing that we encourage is moving and dancing. And so we always encourage individuals, if your loved one or if your family member has a particular wedding song that they enjoyed dancing to, we can always waltz with holding hands. If we're in a chair or in a bed, we can always dance with our hands and still have that physical connection and still have that movement with the music as well. If you have someone who enjoys jazz or has big band preferences, you can always tap your toes while you're moving, just to get your body moving and involved with the music that you're working on together. And so, of course, I brought one for us to do because we always need to get ourselves moving as well. So I just brought a little bit of the Beatles, and we'll do a little bit of twist and shout, and then I'll show you how we might adapt it or how you can adapt it to help with engaging your loved one in something that's a little bit fun too. So get ready to do a little bit of the twist. If you're seated, you can still twist with just your upper body, or you can stand up and do the full twist if you'd like. So here we go. Well, shake it up, baby, now. Shake it up, baby. Twist and shout. Twist and shout. Come on, come on, come on, come on, baby, now. Come on, baby. Work it on now. Work it on now. Now, I might see that someone might not be comfortable doing the twist, but I might see their toes tapping. So I might say, come on and twist or tap your toes. Tap your toes. Can you tap your toes? Tap your toes. Come on, come on, come on. Tap them now. Tap your toes. Work it on out. Work it on out. And then if I know that somebody might be really working on their upper extremity movements and really getting stretched out, I might ask them to start waving their arms or reach for the sky. And so we might sing, well, wave your arms, twist and shout, wave your arms. Come on, baby, now, wave those arms. Work it on out, work it on out. And so then the song provides an opportunity for someone to engage in multiple different movements with something that might be familiar to them as well. So we love to play and to listen and to move together too. And so the next one that was on the list was playing and learning. And it's never too late to learn an instrument or to relearn an instrument. We have sat at the piano with individuals in memory support communities who feel the music back in their fingers and can play songs that they learned decades ago through muscle memory and through that musical imprint that is still there. And we might continue to explore. We might go through lesson books and see what we can bring back in our fingers and what that can do for our overall health and well-being too. And we've also led choirs of adults with Alzheimer's and dementia who not only can pull embedded lyrics from memory and sing those familiar songs like we're talking about, the songs from their childhood or from their adolescence, but also can learn new music as a result of that staying power of the rhythm and melody that we're learning, especially with repetition, with familiar faces on a regular basis to engage in that music together. The other, something else that was on the list is music for activities of daily living. And much like music helps us with orientation to time and space, but it's also a way to mark time and to help alert our loved ones of routines and tasks and help support individuals as they're moving through their day. We have supported individuals with things like hand washing, with teeth brushing, with dressing, or with morning routines, evening routines, or transitions between events and everything in between with music. And so we as the music therapists might write songs to help remind our patients and clients about the steps of a routine, but you can also use recorded music or sing about what you're doing together. For instance, if you have someone, one of my colleagues is actually working with someone right now on teeth brushing, but really loves the song, "Gonna wash that man right out of your hair." And so you can sing that song while you're doing doing bathing, or you can do I'm gonna wash those germs right out of my hands, gonna wash that germs right out of my hands. And just kind of change the words to what you're doing to make it more applicable to the task that you are working on as well. And also putting on preferred music can offer a distraction from what might be a negative kind of association or something that's less desirable to be engaging in. If we're listening to preferred music, we can help pass that time as well and get through some things that might not be preferred activities so that we can sort of distract ourselves with something that is more enjoyable and help with that dopamine production as well. And the other thing that I wanted to mention is putting together playlists of music for loved ones so that we can help reflect a portion of our day or maybe particularly difficult times during the day. So maybe having some instrumental songs for meal times, or having some relaxed songs for the afternoon, or for times that might typically be times of anxiety or distress. Maybe some upbeat and rhythmic songs for times that we need to get our bodies moving. How can we re-engage our muscles and prime our bodies for movement with rhythm and with preferred music that we can dance to? But I also encourage you to find that music that really connects and speaks to the person, because what might speak to one person doesn't have the same impact on another person, and everything is completely individualized. And we know that we can start in our kind of adolescent years with things that are likely familiar, possibly a powerful connection, but it really depends on the individual, and find that music that that person likes. And preference assessments and surveys are such a part of what we do as well, so that we can gather that information and have a real solid starting point for connecting with a person through music. But I also encourage you to introduce new music too. It's never too late to start listening to different kinds of music and different genres. And sometimes I like bringing comparisons of maybe somebody had remade a song from 50 years ago and to see which version we like, which version we might like better. So that can really spark a lot of great discussions. I've had a lot of heated debates over whether or not Elvis is a great musician or just a distraction, and whether Michael Bublé does it better than Frank Sinatra. And so it's really a nice way to not only bring in new music, but also have a discussion about the music and really bring in those talking points too. And I see that we have about 5 minutes left. So I wanted to just pause before we close, but I hope that this helped to provide just a really brief snapshot of why music is so meaningful in the lives of our loved ones. And I hope that you have also learned a few nuggets of information that you can take with you and share with your family or community. I have one closing song, but maybe we can do if there are questions first, or do you want me to do the song first?
Let's see, with you know what, let's do the closing song, and
you got it.
Maybe we'll do a couple of questions.
Sure.
And we'll wrap things up.
All right, it's just a quick little one, but I just wanted to thank you all for your time and for being here as a part of this conference. I'm so excited to be a part of this conference. I learned so much this morning already as well. So I just wanted to say thank you for the music. Thank you for the music, the songs I'm singing. Thanks for all the joy they're bringing. Who can live without it? I'll ask in all honesty. What would life be without a song or a dance? What are we? So I say thank you for the music, for giving it to me. So I say thank you for the music, for giving it to me.
That's wonderful, Leanne. Let me just address a few of these questions, because we like to make these days interactive here.
Sure.
What would you say is the best? Diane asked, what's the best way to connect with a music therapist? And she has a partner who has mild dementia, lives at home. How helpful is it just to having music playing around the house?
Yeah, so two parts to that. The first thing is, I think my email is in the slides that will be shared as well. I'm happy to connect you with a music therapist in your area. It could be us as well. We love to be in the community providing support. Also, the Music Therapy Association, musictherapy.org. There's a section to find a music therapist. Whether you're in Virginia and Maryland, both have music therapy associations where you can find a music therapist in your area as well. And we all network with one another to help find someone close to you who can serve your loved one. And music is very beneficial to have in the background as well. I think it is important to reflect different times of day as well. Something that you might want somebody to be focusing on the task at hand. You might not want to play music that has lyrics, because then we tend to get distracted and want to sing along with the songs. So that's when I sort of recommend more of the instrumental music as well.
Great. And then Diane says, persons with hearing problems sometimes complain about music as being distracting or cover up speech or concentration. Any suggestions on how to get around that?
So I think that that's definitely a valid point, especially when they're happening simultaneously. I think that, what we tend to do is embed the conversation into the music or between the music and pause for things as well. So we sort of leave space for the verbal communication so that there isn't the overlap of distraction too. But that's a great point. Yeah.
And then the last one, and I know we've got more, but we've got to wrap things up. But Diane asks, a different Diane this time, asks, you get involved with just one-on-one with individuals, or is it for groups only?
We do both. Yes, absolutely. And a lot of our clients, when we go to communities and see groups of individuals, then we might spend extra time with individuals or those who might not feel comfortable joining in a group. We absolutely work one-on-one, which is a lot of fun for us too.
Great. Well, Leanne, this has been wonderful. And Dan, our host, is here to transition us to the next segment.
Thank you.
Thank you, Steve. Thank you, Leanne. That was a terrific presentation. And again, the theme of this conference this year is caregiving with inspiration and hope. And both of the lectures today and both of the sessions did just that in different ways. We can find hope in science, and we can find hope and inspiration in creative arts and music as well. I want to remind everybody to, again, visit our exhibit hall if you haven't done so already. The link can be found in the chat. We'll probably be dropping the link back in the chat as well. And now we're going to have a little bit of fun, and we're going to spin for prizes. So we've got a wheel like we did yesterday, and we're going to do it again now.